Okay, we are on. I had to think about it. I'm like, are we on? Okay, we are on. Here we go. And we're live. There we go.
Woohoo.
Hey, Doc, what we're doing, we're just going to wait for a few more people to actually come in. So,
Sounds good.
yep. So, right now we got three people. Hey, Carbon, how are you? Thank you for joining us today. For anybody that's joining right now, if you go to the top of the screen, I actually pinned that top of the screen. So it's the PowerPoint or camera slide that we're going to be using. So if you want to follow along, feel free to follow along as we do this. In addition to that, there are links on certain pictures. So if you click on that link, that'll take you to some of the more credible, reputable websites. How to think about it. I'm going to say reputable websites and references as well. So feel free to go to that as well. But like I said before, we got Dr. Lyons on, and she's going to hit this hard. This is up her avenue when it comes to pelvic pain, endometriosis, preeclampsia, eclampsia, hypertension, heart disease. One of the biggest things we know is dealing with pelvic pain. Not me, because I'm a guy, but even what I learned, which is interesting sidetrack, because I just got a squirrel moment. I didn't realize even guys will have issues with pelvic pain. I didn't realize that. Because when we think about it's always been females and we talk about pelvic, we always thought about females. But when doing some of this research, I'm like, guys actually have this too. It was interesting. So,
Oh, yes. Actually, I referred my first male patient to pelvic floor physical therapy not too long ago. So it is a thing.
wow, that's crazy. I did not know it. I did not know that at all. So now for a guy, is it similar for a guy as well? Not really. For a guy and females, I guess, because when looking at, I know we were talking about the internal organs when it comes to that part about the pelvic floor,
Yes.
but is it similar or somewhat similar? How does that work?
Well, the muscles are the same that are
Mhm.
in the area. It's just a different configuration to accommodate the reproductive organs.
Mhm.
And so some of the same things that we're going to talk about in a little bit that can contribute to pelvic floor dysfunction, one of them being like obesity or significant straining. For instance, like weightlifters who do a lot of heavy lifting, that can also cause issues there too. So, or even chronic constipation. That's a big one. That is a really big one that can strain the pelvis.
Wow, I didn't know that. What up, Coy?
Hey, what's going on?
What's up with you? What's up with you?
How y'all doing? How y'all doing?
Good, good. I was telling Dr. Lyons, Derek won't be here today. Lord, his son made the playoffs. So, right. So, and it was a rain delay. So on Saturday, they made the playoffs. It was a rain delay. They played, I think, 4 innings. They didn't say, hey, it's a rain delay because of a bad storm. They said they're going to finish it today. So I guess around this, I think it's around 6:30 Pacific time, I'm thinking. So about an hour or so.
Yeah.
So more likely he's not going to be able to make it. So what we did, so I know in here we're going to hit hypertension, heart disease. That's right up your avenue, especially when it comes to holistic medicine. So I love to hit that as well. I'm going to add to that. Carbon said one thing before you even dive in there and get started. Carbon said one thing here is the same as a pelvic tilt. So what is a pelvic tilt?
So a pelvic tilt is how the pelvis sits in your body. And so it kind of varies because it is attached to your spine. And so your spine naturally has a curve, and the pelvis can either be tilted different ways depending on how the muscles are. So like if a patient is very tight, that can also cause the pelvis to shift. If one muscle group is stronger than the other, or one area or aspect of the muscles are tighter than the other, then that can cause the pelvis to tilt in other ways. But there is a natural pelvic tilt that occurs.
So Dr. Corey, going back to NASM with the squat, the overhead squat assessment. So that'd be like the anterior pelvic tilt, anterior shift, and all of that. Is that what that's doing? Okay.
Absolutely. And you spoke about it, Dr. Lyons. I mean, when you have the spine that holds your nervous system, of course, and also you have that pelvis that connects the spine to the lower extremity. And so a lot of, that's where our stability comes from, right there in that pelvis. A lot of things happen in that area, of course. A lot of muscles, ligaments, tendons connect there. And so basically the pelvis can tilt front or back, and then each ilium or each hip has its own motion. And it's almost like Legos. So you have a right ilium, a left ilium, and also your sacrum that sits in the back there that helps to connect your spine to the lower extremity there. And so oftentimes when you have issues with muscle tightness or weakness, especially we attribute it to low back pain, those issues where, over 80% of people are going to have some type of low back pain in their lifetime. A lot of it comes from the hips and how it's holding the weight of the body there from connecting the upper extremity to the lower extremity.
Okay, cool. Makes sense. Now I'm bringing it all together. It's weird that on this live, I've been a personal trainer under NASM for 15 years, and it's actually starting to make more. I know, right? And it's starting to make more sense now. Look, I go through the SWOT assessment. I do all of this. I'm good with anatomy, physiology, but now I'm bringing it all together, especially hitting with these lives. It's like this is starting to make more sense now. But actually seeing more of the injuries, especially when it comes to the lower body, that I can actually tie it in. So that's why I actually like it. If nobody else loves this, hey, I love it.
That's right. That's right. No, don't worry about it.
Right, so with that said, let's move on. We got about 5 people on. And more people going to catch up when they get on. For those that are just joined, like I said before, at the top of the live or at the top of the chat, there is a link. If you click on that link, you can follow along with us as we go through the PowerPoint or Canvas slide. Anytime you have questions, drop it in there. And just like always, we're going to ask you all questions too, because we love crowd participation. So again, if you have questions, drop them. With that said, Dr. Lyons, take it away.
Okay, so here's basically an overview of what we're going to discuss here. I believe that I will kick it off and start talking about chronic pelvic pain. We will hit on some endometriosis as well, and then transition into hypertensive disorders, specifically talking about preeclampsia and eclampsia that can happen during pregnancy. And then we will also transition again into talking more specifically about hypertension outside of pregnancy, heart disease, and then uplift everyone with some preventative measures and things that we all can do to help prevent some of those things. Okay, so women's health, kind of a hot button issue here lately. But it's very, very important because basically half of the world's population are women. And so we do know that because we're women, or not we, just me on this live, but a lot of our viewers are probably women. Are between the sexes. So with that being said, there's also different symptoms that can come along with all of those things as well. Things can be underdiagnosed either for patients not seeking treatment or presenting with symptoms to a doctor and it either being overlooked or not worked up appropriately. And then it's also important just to be aware of all of these things because all of us are definitely connected to a woman if we're not a woman ourselves and have some of these issues as well. And it's always important to educate ourselves. Okay, so this is a pretty heavy topic that we're going to get into that has a lot of components to it. So we're talking mainly about chronic pelvic pain in women, but I will give a quick note to acute pelvic pain. So acute pelvic pain is any pelvic pain that is below the umbilicus or the belly button that occurs for less than 3 months. And so in women, there can be various causes, just like in chronic pelvic pain. Some of those acute things include such things as sexually transmitted infections. There can be some acute musculoskeletal disorders. There can be some urinary tract infections. There can be pelvic trauma from, unfortunately, abuse or a traumatic accident. And so those things, just remember acute, less than 3 months. Now, for chronic pelvic pain in women, that is pain below the umbilicus or the belly button that occurs for 3 months or longer. And it's pretty significant to the patient where they are noticing it. A lot of times patients really just deal with it and go along with it. They may do their own self-recovery measures. that may or may not work. A lot of people just press through, but it lasts longer than 3 months and can cause them significant trauma in that area, or just continual nagging pain that is annoying, that either causes them to seek treatment or normalize it themselves and they continue to press through. And so different causes we'll get into in a second, but it can be caused by one specific thing in the pelvis, or it can be a combination of different factors that contribute to that pain. And then lastly, chronic pelvic pain affects between 4 to 16% is kind of a widespread, but about 15%-ish of women. However, 1/3 of those are only seek treatment. And so that goes back to what we were talking about on the previous slide, where things are kind of underdiagnosed because a lot of women don't seek treatment.
So I got a question.
Yes.
I know you said STI, and is there truly a difference between STI and STD? Is pretty much the same, as interchangeable, or how is
It's
that?
the same. It's semantics.
Okay.
I think whoever comes up with the nomenclature, they wanted to get away from calling it a disease and pushing it more so towards infection. So
Okay. Is that more like because it can be treated, certain ones can be treated, so it's technically not a disease? I know this is off topic. I was just wondering.
to my knowledge, it is all semantics, but I'm sure there's some other reasoning behind that.
I got you. We go with that.
Okay, so what are some gynecologic causes of pelvic pain? So these are all the things that are within my purview as an OBGYN. And so I've listed some common ones here on the right. So number one is endometriosis. For those who don't know, endometriosis is where the lining of the uterus that is usually shed when a woman has their period, it actually is outside of the lining of the uterus. And so that can be anywhere within the uterus itself, within the musculature, and I'll talk about that in a second. It can be inside the abdominal pelvis. The most common place for it to be found is within the ovaries, but research has shown that it can be anywhere inside the abdominal cavity, or even within the skin or the subcutaneous layers of the body. So it's been found in the lungs, it's been found in the intestines, it's been found deep in the pelvis. Sometimes there are deep nodules that we cannot see with the naked eye. It can be found in skin. Like I said before, there's been plenty of case studies that mention that endometriosis nodules have been found in C-section scars, which is very interesting. And as I mentioned before, it can even be found within the uterus itself. So if you think about it, the uterus, it has several different layers. So there's the inside layer, which is called the mucosa. And that is where your lining is. That is where it's normally supposed to be. That is what sheds when you have your period. Then you have the muscle layer, and that is the layer that expands when a woman is pregnant. That is the layer that gives you cramps when you're having your period, or even experiencing childbirth labor. And then the outside is the serosa, which is basically the covering of the uterus. And so in endometriosis of the uterus, which is called adenomyosis, that lining of the uterus, the mucosa on the inside, actually invades into the muscle. And so it causes little pockets of the uterine lining to form, and they respond to hormones just like the lining of the uterus does. So when you're on your period, those things can kind of swell, they can cause even more pain, they can cause more bleeding. And so that is one cause of pelvic pain. Another common cause are fibroids. And so fibroids, the medical term is leiomyoma. And fun fact, fibroids can be found outside of the uterus. Fibroids are found anywhere there is smooth muscle. So technically, they can also be found inside your small intestine, which is lined with smooth muscle. But we commonly associate fibroids or leiomyomas with the uterus. And so these are small, benign growths. They're usually benign, like 99%. There are others that transform into cancer, but it's very, very low risk for that happening. And so these fibroids, like I said, can be found anywhere inside the uterus. They can be found in that mucosal layer on the inside, within the muscle, hanging out on the outside of the uterus. They can be hanging off the side of the uterus like another fallopian tube. Very interesting. And so they come in different shapes and sizes as well. I've seen some as big as volleyballs that I have taken out, which are kind of fun to do. But I've also seen really teeny tiny ones that are seen on ultrasound, or even when I'm doing small procedures inside the uterus with a camera, you can see them. They're probably less than a penny size, maybe dime size, that are inside the uterus. And so those, if they're large enough or if they're interfering enough with the lining of the uterus when you're having your period and having those contractions happening to push out the lining of the uterus and also help control bleeding, that can also lead to chronic pelvic pain. Additionally, ovarian cysts, that is a major one as well. Some patients have cysts that recur. And the most commonly, this happens in patients who, when you ovulate, let me back up. So when you go through your cycle and you ovulate, that means a mature egg has burst through the ovary and it's headed towards the uterus. And so what's left behind is the nourishing sac that the mature egg was in, and that typically forms a cyst. And so that happens every time that you ovulate. Sometimes those cysts can get a hemorrhage in them, so there can be bleeding that occurs within that cyst. They can grow larger and larger and filled with blood. There can be endometriosis, like I mentioned, in the ovary, that are what we call chocolate-filled cysts, which are basically old blood trapped within a cyst, and those can be pretty large. And then there's other cysts that can happen, some that are cancerous. Most of the time they are not. Some are just fluid-filled sacs that just grow and grow and grow, and those can cause pain. If they rupture, they can cause tremendous amounts of pain. And so that is one cause of bleeding. I think I saw a question. Was there a question?
No. Barbecue. Yeah, which comment? Barbecue was just talking about volleyball, the size of a volleyball.
Yeah, it was humongous. And
Sorry, got a question for you. So you're talking about the size of volleyball. So I know this is somewhat off topic per se, theoretically. So when it comes to endometriosis, or you're talking about the lining of the uterus. So when it comes to the lining of the uterus, for those, because I know I'm about to jump way ahead, for those in perimenopause. Okay. So for those in perimenopause, or for those that have endometriosis, with the line of views, do you commonly see, or is it common to see a female with a very thick lining of the uterus? And even though they're doing that time of the month and they shed the uterus, but it's so heavy and it lasts for maybe 2 weeks, 3 weeks, something like that. Is that common or what? Because again, I guess it's perimenopause, so I'm not familiar with that. I was just wondering.
Well, it depends. The perimenopausal period is very interesting because the hormones are changing. They're all over the place. And so with that, it can wreak havoc on the cycling, the length of the period, the flow of the period, all of that kind of stuff. So to answer your question, yes, the lining could be thick, and yes, you could bleed a lot, but typically prolonged bleeding like you're talking about, like weeks and weeks at a time, that is not normal. And not something that I typically see in perimenopausal patients. What I typically see is that they're like, oh, my period didn't come this month. It came the month before, or I am having my period, but it's only happening for like 3 days instead of my full 7, or it's a little bit heavier now and now it's not. But like bleeding for weeks and weeks and weeks, no, I don't typically see that. So if they were having bleeding like that, they need to come see me.
Gotcha. I was just wondering.
Yeah. But in other instances, I know the last webinar we were talking about PCOS. And so what we get concerned about is the buildup of the lining, because if that is happening, then that can also transform into something different, which we don't want, which is precancer or even cancer. And so patients can have the bleeding that you're talking about with things like that. Okay. Did I answer your question? I wasn't finished.
My bad. I'm going back. I realize that. My bad.
Okay, so those are the ovarian cysts. Another thing is scar tissue. So ladies in the audience, or fellas who has a woman in their life who have had surgery, any type of surgery in the abdomen counts. So C-sections obviously are a big one that we think about, but if there has been some other surgery that has occurred, like having your appendix out, let me think about what else. That's probably the biggest one. Or if you've had like some sort of unfortunate trauma where you've had to have a big abdominal surgery or some sort of colon surgery, anytime a surgeon goes in your belly, there is scar tissue that forms. Now, how much or how little that forms, it's indeterminable, because I've been in some patients who have had one C-section and it looks like they've had 5. And then I've been in C-sections where patients have had 5 C-sections and it looks pristine. So we never can tell how all of that works. Carbon Q, we're getting there. And so scar tissue, what it does is it distorts the normal anatomy. And so it can encompass nerves and things. And so that can cause a pain or pull or tug on different structures inside the pelvis. And that can lead to pain as well. And then finally, this is not an exhaustive list, but this is kind of the most common things. And the last thing is cancer. So if you have some sort of malignancy within the uterus or the ovaries, that could cause pain. But as we'll talk about in a second, cancer in other areas of the abdomen can lead to pain as well. So colon cancer, et cetera, et cetera. Next. Okay, so some non-gynecologic causes of pelvic pain. So a big one is GI disorders. And so before I get into all of these, the reason why it is important to have a comprehensive workup when you come for pelvic pain is that we are trying to rule out all of these other things, because there's a lot of stuff in your abdomen below your belly button. So you have many feet of intestines inside your abdomen. Your bladder is there. Your kidneys, they're kind of in that area. Like they just make the cutoff. Then you have many muscles in the pelvic floor, et cetera, and the nerves. I mean, the nerves are everywhere. So we do a comprehensive exam and workup just to make sure that we are isolating the specific thing, or we try to isolate the specific thing that is causing your pain. But again, as I mentioned in the first chronic pelvic pain slide, it could be multifactorial. It could be a combination of those different things. Okay, so talking about gastrointestinal disorders, these include things such as irritable bowel syndrome, inflammatory bowel syndrome, which includes ulcerative colitis, or what is the other one that I'm blanking on right now? UC and Crohn's disease. And so those are kind of the big ones that I see, specifically irritable bowel syndrome. But other things such as diverticulitis, which are basically little outpouchings of the colon, celiac disease, which is a gluten sensitivity issue within the colon, and even chronic constipation, which I talked about before, because that can put stress and strain on the muscles of the pelvic floor. Moving along to urinary tract disorders, those include things such as recurrent or chronic UTIs. The big thing here is something called interstitial cystitis, which is kind of an older term. Now they call it bladder pain syndrome. And essentially, this disorder kind of presents like a UTI, but patients have many cultures of their urine that are negative. And so when they do that, we kind of get suspicious for this type of disorder, and that's specifically with the bladder. Other things such as kidney stones, if it's chronic, I mean, to have a kidney stone for 3 months, yikes, that is terrible. Hopefully it would be found before then, but that could also be something that could lead to chronic pelvic pain. Another one is something called a urethral diverticulum. So the urethra is what carries the urine out of the body, and sometimes there can be an outpouching of that tube as well that can cause some pain as urine kind of collects in that area. The next area is musculoskeletal. So we've touched on this a little bit already. There's many muscles in the pelvis, like Dr. Coy was mentioning before, that connect to your hips, that connect to the other musculature in the pelvis. And so if you have trigger points there, if for my ladies who have carried babies or had vaginal deliveries, definitely the strain of having a fetus sitting on your pelvis for 9 to 10 months and then pushing the baby out using all of those muscles, because by the way, the same muscles that you use to push are the same muscles that you use to push poop out. So all of those muscles can be traumatized in carrying and delivering a child. So all of those things can lead to chronic pelvic pain as well. And then other disorders of the musculoskeletal system, including fibromyalgia and other trigger points, which are basically like knots of muscle within the muscle bands that can lead to pain. And then last but not least, again, not an exhaustive list, are neurological things. So I mentioned before that with scar tissue, you can have nerve entrapment. So that can happen as well. And that can cause pretty significant pain as well.
Hey, quick question for you.
Yeah.
So jumping back real quick, sorry about that. For endometriosis,
Yes.
if somebody's had a DNC, not sure if you want to explain what DNC, if somebody had a DNC, does that increase the chances of endometriosis, or is that like two separate things?
So yes, it can.
Okay.
So a DNC is short for dilation and curettage. It's most commonly associated with patients who have who desire a termination of pregnancy, or for patients who have been diagnosed with what we call a missed abortion, which basically is a baby inside the uterus without a heartbeat, who desire surgery, go in and clean out the uterus. Additionally, we do that for patients who have abnormal bleeding that we are trying to investigate. Mm-hmm. And so with doing the procedure, usually it's not something that we can cause, but sometimes if doctors are overzealous in trying to really clear out the uterus and get appropriate samples, sometimes you can go too deep and actually get into the muscle, and that can lead to endometriosis as well.
Oh, okay. Mm-hmm. Good question. I mean, good thing, because I was just wondering how that would be with the DNC, because I hear it all the time. I'm YouTube University, so I hear that all the time, and I'm like, okay, with a DNC. Yeah. Now, is that with, because I'm not familiar with, is that with a scalpel? Is that with heat? Or, because I didn't say they go in.
No, so it can be done two different ways. So typically in a pregnancy situation, it is done blindly or under ultrasound guidance, and it involves using basically like a really large straw, like maybe like that much in diameter, like 7 millimeters to 1 centimeter in diameter. And so it's hooked up to a vacuum machine. And so basically we go inside the uterus, cut the vacuum on, circle it around, and that is what clears out the uterus.
Okay.
Alternatively, if we're doing it for patients who have abnormal bleeding or continuing to bleed, or we know that they've had a miscarriage but haven't like cleared everything out, we can do a DNC with direct visualization. So we use something called a hysteroscope, which is basically a camera that goes inside the uterus. We visualize what we're going to take, and we have different materials that can basically chomp away at the areas that we want to sample. Old school way, we could use something called I am blanking on the name, but essentially we use heat to go in and basically skim off the lining of the uterus. So those are the different ways that it can be done.
Okay. Jovan says something about, what about ectopic pregnancy? So I know we were talking so much about other things. So Jovan, what do you mean when you say, what about, you talking about for excessive bleeding or pelvic pain or what? Because I know we were discussing several things, and when I put it up, I forgot which we were talking about at that moment. So if you just drop it in the chat, let us know, and I'll pull it up for Doc.
Definitely. While that person is modifying their question, another thing that can cause adenomyosis, which is endometriosis of the uterus, is C-sections. So if you think about it, we're cutting through the full thickness of the uterus when we're getting to the baby. So that's the serosa, that's the muscle, and that's the mucosa. And the mucosa is where the lining is. And so when we're repairing that, oftentimes we will repair it all together. So that is an impetus to introduce the lining of the uterus into the muscle.
And that causes a lot, and because I know you talk about scar tissue, and that causes a lot of scar tissue as well.
It could. Like I said, I've been in some C-sections, like they've only had one abdominal surgery, and that was a C-section before. And it's like, wow, it's really like cement in here. And then others who've had multiple, and it's really not that bad. So it just depends on how the patient heals. But either way, there's going to be some scar tissue in the belly.
Oh, okay, cool. Did you talk about neurological before we jump on? I don't want to jump ahead.
Yes, I did.
Yeah, okay. See, keep me on track. Keep me on track. So here we're talking about preeclampsia and eclampsia. For me as EMS, we see this a lot. I won't say see it a lot. We see the preeclampsia at first. And for a lot of females, for our end, for those that are not receiving the prenatal care that they're supposed to receive. Mm-hmm. So a lot of times they tend to call us about abnormal pain or abdominal pain or stuff of that nature. So when we get there, they have high blood pressure and stuff like this. So for us, on our aspect, there's not much we can do. All we can do is just control the blood pressure, try to bring it down as much as possible while we get them to the hospital. So for you, I know this is one, like I say, is your bread and butter. Can you explain this part to them?
Yes, absolutely. So preeclampsia and eclampsia only occur in pregnancy or immediately postpartum. And when I say immediately, I mean, it kind of doesn't make sense, but it is within the 6 weeks of giving birth. So you could technically have preeclampsia up to that point, preeclampsia or eclampsia, but most of the time it's within a few days of giving birth or within a week. So preeclampsia and eclampsia, they are hypertensive disorders of pregnancy on the more severe end of the spectrum. So you have patients who don't have any high blood pressure at all. You have patients who have high blood pressure outside of pregnancy. You have patients who develop high blood pressure within pregnancy that's not diagnosed as preeclampsia. And then you get to preeclampsia and eclampsia on the severe end. So preeclampsia is a disorder that involves elevated blood pressures, but also symptoms and or lab abnormalities. And so that's what we mean by when we say proteinuria or organ damage. And so to be diagnosed with preeclampsia, it is usually something that occurs after 20 weeks, but most likely in the third trimester, so after week 28. And so when a patient has symptoms, and I'll jump down a little bit, the symptoms are things that are severe and persistent. That's what I tell my patients. If you have any of these things and you take something and it goes away, it might not be, but it's something to bring up at your next visit. But if it is still going strong and you've taken a lot of Tylenol, you've rested, you've eaten, you're hydrated, and you're still having a 10 out of 10 headache, that is not normal. You should come in and see us. So severe persistent headache, vision changes such as spots in your vision or blurry vision, swelling in your lower limbs. I tell my patients that is normal for the third trimester. And I need to find another analogy, I think, as I continue to grow in this profession, because most of my patients know what the Michelin Man is, but I've had some who are like, who is the Michelin Man? So I need to find a more up-to-date reference. But for all of us here, I hope we know who the Michelin Man is. But I tell them, if you start looking like the Michelin Man within a few days, that's not normal. And I have seen that, like, patients just look really, really puffy, and it's within a few days. That is not normal. Right upper quadrant pain. So that is actually caused by swelling within the capsule of the liver. So the liver also has a covering. And so with preeclampsia, that can cause swelling around that capsule. And that's what causes the right upper quadrant pain. Patients can have shortness of breath, which comes with pregnancy, especially as the belly grows, but it is more pronounced. So really working hard to breathe at rest. So you're sitting down and you're gasping for air, not normal. And then lastly, chest pain. So significant chest pain in pregnancy, a lot of times that is caused by acid reflux. But if you are having kind of crushing, severe chest pain, not normal, need to come in. So patients can be diagnosed with high blood pressures and a combination of those symptoms, or high blood pressure and lab abnormalities, specifically proteinuria, which is excess protein in your urine. And so your doctors will know the cutoff for that. But if you have excess protein in your urine and high blood pressure, then you will have the diagnosis of preeclampsia. Now, there's levels to preeclampsia as well. So there's preeclampsia without severe features, which is basically elevated blood pressure with increase in protein. Preeclampsia with severe features is elevated blood pressures and symptoms that are severe and persistent, like we talked about, or elevated blood pressures and signs of end organ damage, which means that we see signs of severe anemia. We can see signs of severe low platelets, which is usually less than 100,000. Excuse me. We can see elevations in your liver enzymes. And so if we see any of those things, then you are diagnosed with severe. And so what we typically do is give you magnesium, which makes patients feel great. I'm being facetious. Magnesium makes patients feel terrible. And so that's what we typically use to treat patients. Eclampsia is, you've already been diagnosed with preeclampsia. We've got that going. Usually if it's severe, we will have you on the magnesium. The magnesium is used to prevent seizures, but eclampsia is preeclampsia with seizure activity. And so it can be quite scary in the moment, but we usually just provide supportive care to the mom. A common question we get is, do you immediately rush back and deliver? Because a lot of times the baby's on the monitor, their heart rate goes down. We typically don't, because once the mom has recovered, the baby will recover. And then we usually wait and then go back for a C-section at that point. But like I said, so if you're diagnosed with preeclampsia or eclampsia, specifically preeclampsia with severe features, and we're already treating you with magnesium, the ultimate treatment is delivery, which is kind of oxymoronic because patients can get preeclampsia or eclampsia postpartum. Still trying to work out how or why that happens, but the diagnosis is delivery, so getting the baby out. Now, if you have preeclampsia without severe features or preeclampsia with severe features and your symptoms are controlled, your blood pressures are controlled, we can wait to have you try for a vaginal delivery if that's what you want. If you have preeclampsia with severe features and your blood pressures are still all over the place, not in a good place, then we'll most likely say, hey, we need to move towards delivery to make sure that you and the baby are okay, because those hypertensive disorders can cause significant damage to you as the patient, but also to the baby, because it can make, for instance, the placenta come off early, which is a surgical emergency. So that is preeclampsia and eclampsia in a nutshell. And I mean, there could be a whole presentation on that, but that is just like the 5-minute spiel.
I just had somebody ask, when you going to go into private practice? Because the military.
Me?
Yeah, they said military doesn't need you anymore. They need you. The civilians need you now.
I wish, but I'm having so much fun in the military. I have a lot of years left. I don't know, but I am doing some locums work. So if you are in the Northern Virginia area, I got you.
Y'all hear that? If you're in the Northern Virginia area, just let you know. We got the best of the best on the board with us now. So take a look. These two are the best. I mean, my brother's all right, but he's my brother, so. But these some good ones up there. So, yo, chat, y'all hit them up. Okay, I'll be quiet. Here we go. So hypertension in women. So both of y'all can tackle this. Dr. Coy, did you want to hit this real quick or talk about this?
Yeah. With hypertension from a functional medicine standpoint, obviously, the cardiovascular system is important to the body. It pumps blood throughout the body for nourishment to keep us alive. But, when we look at hypertension, when we take our blood pressure, when it's above, 120/80, that's the new norm these days. That's what's deemed hypertension or high blood pressure. And this slide really, talks about it in many ways. And a lot of times in regard to women, it can be a silent killer. I mean, when we look at the prevalence of heart disease and heart attack and stroke, our women are very strong and resilient. And a lot of times, depending on the circumstances of which they're living in, unfortunately, sometimes they can mask things and they take on a lot of stresses. And so sometimes they can come across as asymptomatic, meaning no symptoms. They don't realize it. There's no sign. There's no dizziness. There's no issues with their health from what they see on the surface, but underneath the surface, there's a lot of things going on. So for me, this really segues into the risk factors. A lot of times I see this all the time where a person or a female is having some issues with their weight for various reasons. So obesity, obviously the traditional medical model will look at BMI as a way to grade a person's height and in reference to their weight, which we can go, that's a whole nother topic with how BMI is, but it just gives you a ballpark reading of, okay, how in shape this person is, whether they're a good weight or they are obese. And so when you look at these risk factors and you put them all together with stress, I mean, who's not stressed these days, right? Gravity is a stress. So we have that. And then they link up all these other risk factors like physical inactivity and diet, and obviously type 2 diabetes, which that's up my alley. Actually doing a webinar tomorrow with how to reverse type 2 diabetes tomorrow. But, diabetes is an issue. And then these other risk factors that oftentimes, in my opinion, really don't matter, but age and family history, and obviously pregnancy complications. So all these put together, sometimes if they have little issues, and I look at it from standpoint of if it's not a 10 out of 10 issue, then it's not a problem, right? So, many of those risk factors, they're there, but they are not, all right, emergency. And so that's why I say a lot of times women can be very resilient, and they'll just push past many of these things. They'll push past the stress. Well, they haven't gotten a lot of activity, and, that can lead to obesity and all these other things. And obviously with type 2 diabetes, and there are a multitude of reasons why a person can be a type 2 diabetic. So all these things come together in just one hodgepodge of risk factors there. And so obviously with prevention, when you look at the risk factors, you obviously can then flip-flop it and say, okay, what are the aspects of life that can help reverse that or help put the person in the best position? Yeah, you need to have a good, healthy weight. Yes, you need to have activity. Yes, you need a healthy diet, eating good food and drinking clean water, right? And managing your stress. And if you do have an issue with blood pressure, tracking it, taking your blood pressure. Sometimes you may have to take your blood pressure standing up, sometimes laying down, sometimes sitting, different positions to see how your body's reacting to that. Get one reading on one arm, go to the other arm to track it, because it's good to make sure that you're educating yourself on how everything's going, but also then you can communicate effectively to your doctors that are obviously, if you're hypertensive, you're going to be taking some type of medication, and there's going to be side effects and repercussions as a result of that. So you want to be able to have educated conversations with your doctors, and obviously, seeing your doctor for those things is very important.
Doc, you want to add on to it?
No, that was a great explanation. The only thing that I wanted to say was that under prevention, I think all of those things are good. But for the ladies in the room, just know that once you hit menopause, your protection that you get from your estrogen kind of goes away. And so your risk for heart disease and even hypertension, all of those things, they go up at that point. So if you're premenopausal, the estrogen is actually protecting you from heart disease, even though you can still develop it, but it is a protective factor.
So
See it all the time.
how does that work? Because you said it's protective factor. So what exactly does the estrogen do when in that aspect of the protection for heart disease? How does that work?
That's a good question. You are asking a scientific researcher question.
Oh, okay.
I would have to find a paper for you. But there is plenty of research to support that aspect of it. The how of it, I am not sure, but I have read the literature that has said that is a protective factor for premenopausal patients, and so their risk for heart disease and all of that goes up after.
So I'm gonna actually go look at it now. I'm gonna go to Chat GPT. Make it easy for me. No.
Health initiative.
No, I'm gonna actually look that up because we got exams this week anyway. So that'll be something interesting because I would like to know exactly how does the estrogen. I'm more on the scientific aspect of it. I would like to know how does that actually work. So that's perfect. I actually like that. Thank you.
Well, let me jump back into the hypertension conversation because oftentimes I don't know it can seem as to folks to be a topic to minimize, and it's very important to use it as a gauge. I kind of look at it as a temperature gauge on how the body is either in balance or is not. First of all, when you're checking your blood pressure, you got to make sure you got the right equipment and the right cuff, for the arm, so if your arm has a lot of girth on it, you don't want to get the small cuff. So that's going to throw off your readings. And so the other aspect of it is that understand that when you get that reading, it's going to tell you certain things about you. And so when a person is not having symptoms, but they see that their blood pressure is up, is very important to take it for what it is and then just kind of backtrack and look at these risk factors and be very open and honest about those things, because the number one killer of individuals today is heart disease. And again, these are things that can come at like a thief in the night, and you're here today and gone tomorrow. So it's super important, again, as women that are a driving force in our society, of course, and doing lots of things, to take time to stop and listen to their bodies. So can you explain why the wrist cuffs are very inaccurate compared to the arm? That's a good question. And I would say, I don't know the exact reason why they are inaccurate that way, but I think the easier way to look at it is, if you have a home unit, I think it's good to compare it to the unit or the machine or device with your medical professional. Like sometimes I always recommend that you take the cuff or the machine with you to your doctor's appointment. So when you get your blood pressure taken there, you can compare, okay, let me check mine. It's going to be different. So even the same machine, like you go to a CVS or a Walgreens and get a cuff from there, or get something online that's a home unit, you get this exact same thing and put it on your arm, you're going to get different readings, right? But it's good for you to kind of compare apples to apples, oranges to oranges, but also have that comparison with your doctor's reading and doctor's cuff, so that you can be able to have, okay, this is the degree of error here, or, I have an idea what's going on, so that you can communicate that. How often should someone take their personal machine with them to the doctors? I mean, again, I think it's just a matter of you gauging what the reading you have at the doctor's office versus what you have at home. Oftentimes, sometimes patients will have that white coat syndrome where, you know, I don't want to go to the doctor. And then, you know, I hate the doctor. And then next thing you know, their blood pressure's through the roof. Right. And, you know, so that's a whole nother factor that goes along with that. So again, that's why I say, hey, take your blood pressure cuff at home. Your readings at home, do it standing, sitting, or whatever. And I've seen patients of mine, they have cuffs from their doctor and they get the readings shipped off straight to their doctor. And, you know, if something, you know, they get a bad reading or something, their doctor's calling them. So technology is much different now. So
I'm gonna jump on this real quick. G23, when he talked about that, if you think about it, your brachial artery is a larger vessel. Because it's a larger vessel, it has more pressure pushing through. However, when you travel down from your brachial artery and you go into your radial artery, it's thinner. Because it's thin, and I should say because it's thin, you're pushing more pressure in that area. So it tends to have a higher reading because it's a higher pressure compared to the brachial artery, which is a little more dilated or wider. That's where that comes to play. And also because it's further from the heart and you have that gravity, so that's another effect. So the ones in the risk are going to be higher, slightly higher. It could, like you say, Dr. Corey said, take it to the doctor, but they tend to be slightly higher due to that reason. But also you have to factor in your fluid intake, your diet, and things of that nature, because that will affect it as well. Dr. Lyons, you want to add anything about that?
No, I definitely agree with both points. With Dr. Coy saying bring in your cuff, I would say anytime you have a new device, definitely bring it in so that you can calibrate it against your doctor's device. Or you could bring it in if you see them quarterly. You could bring it in, you know, every other visit just to make sure your device is still on track. I don't know that you need to bring it to every single one,
right.
But definitely if you get a new one, or if you want to compare once or twice a year to make sure your device is still working appropriately.
Yeah, cool.
That's so that comment about the blood pressure, you know, the spikes. I mean, with the blood pressure, I mean that's stress, right? That's that flight or fright, you know, coming into play, you know. So definitely.
So it talks about why might hypertension be overlooked in younger women. So both of y'all, because y'all have your patients varying ages as well. So in this case, when you think about it, why is it that somebody in their 20s, mid-20s, early 30s, their hypertension may be overlooked compared to somebody that's older? I know one would be, hey, if you're younger, it's more or less your diet or something of that nature, where they really don't factor in the family history. But what are some other reasons for that?
They don't care.
Ageism.
Like, did you care about your blood pressure? I mean, you try to get to the next party, especially in school. Like you trying to get to the next, you know, party. You trying to pass a test. You're trying to get through life. It's all about, man. You got an S on your chest.
Do you have insurance?
Yeah, like insurance, like car insurance, like okay, you know. So they don't care. But in all seriousness, though, the way things are going these days, like the things that are what used to be deemed old people, these are, I mean, we're getting younger and younger and younger. And so that's primarily, you know, where I'm always like, okay, well, I don't want to get to the point where we have, you know, with these statistics that we're seeing, younger and younger patients, you know, having heart attack and stroke and diabetes and all these things, you know, and these are metabolic syndrome type things. But we're seeing that day in and day out. And a lot of it is just our lifestyle. And, you know, if lifestyle is not disciplined, you know, there's going to be some consequences to that. And I think that's just something that we can't overlook. But the younger population, they got an S on their chest, you know?
Yeah. I mean, let's be honest. Knocking back them Red Bulls, hitting that Adderall so you can do all-nighter study sessions.
Horrible. it's like, you know, but then it's going to create so many other issues on the back end of it, stress and breakdowns and all that other stuff too. So there's going to be a shutdown too. So it's an issue.
Oh yeah. All right, so what about this? When talking about heart disease in women, let me see if I can enlarge this screen. Here we go. Heart disease in women. Either one of y'all.
Yeah. I mean, the risks are there. It's the older age and menopause. Yeah, I can get that, but I mean, it's prevalent in all ages, and even pre-menopause there, and obviously with exercise. We have to be careful though. A lot of times too, is that lack of exercise can often be a problem. Where you go to the doctor and they tell you, oh yeah, you need to go get to the gym. Well, sometimes that person is not fit to go to the gym at that time. And then that ends up causing a stress or an issue. And so we have to be very careful on these generalized recommendations, because it's important to make sure that your body and how things are. Yes, you need to eat well, like put away the saturated fats, put away the fast food, eat foods that are nourishing, that's going to give you the vitamins and minerals, the proteins that you need. So it's very, very important there. Smoking, wow, that's a big one. Like smoking, tobacco use, and that includes vaping. Right? These are the things that we're seeing now. I've seen this with numerous patients of mine. And science is always 20 years behind. So, we don't even know how the impact vaping is going to have on folks. But you're just pumping chemicals into your body that could be be forever chemicals. So if you know about smoking, that's a big risk factor for that. And then obviously blood sugar. So again, much like blood pressure, I look at blood pressure and blood sugar almost the same. It's just giving you a different gauge. It's from a different vantage point there. So, so women, you're coming in first on this one. You come across the finish line, leading cause of death. That's not a good way to die. And even the symptoms, some of these symptoms, again, you may just be overlooking this, but you can't. You're looking at fatigue, nausea, pain in the jaw, or the back, thinking it's just that old school back pain. It can be signs of a heart attack, right? But it's just important to recognize these things.
Yeah, that's actually one of the things. It's amazing because females, and Dr. Lines, you talk about that as well. For us, we had a 911 call with a woman. She was talking about, I'm just having back pain. It's pain between my shoulder blades. And, we go through our sample. And I'm going, okay, let's go through everything. Then I say, hey, are you diabetic? Yes, I'm diabetic. I'm type 2 diabetic. Okay. Then we're going through everything. I'm like, okay, what type of medical histories besides diabetes do you have? She said, that's it. I'm like, and family history of heart attacks? Yes. Then the typical cool, pale, diaphoretic. I'm like, ma'am, you're having a massive heart attack right now. We put on the EKG. She was throwing a type 2.
Wow.
Yeah, type 2 block. I was like, oh crap, this is not good at all. And for those that don't know what it is, it's bad. Just know it's bad. It just means her ventricles and atrials not function like they're supposed to. It's a signal loss, and it's real bad. So she was actually having a very bad heart attack. And just the fact that my partner is used to the mid-sternum chest pain radiating to the left arm, and she wasn't having that. Hers were in the back. It's like, for women, it's going to be different. And that's when they teach us in paramedic school. Women symptoms are going to be totally different from that of men. They may have similar things as men, but theirs going to be totally different. And that's what we actually have to get used to. So, but yeah. Dr. Lyons, you want to say anything about that?
No, I agree. I think I mentioned it earlier, because the sexes are so different, it's not surprising that our symptoms for different things are different as well. And so like you just brought up, to the uneducated, they may be looking for those things. I know that TV kind of depicts the standard male symptoms when it comes to a heart attack. And so when others are encountering actual heart attacks within themselves and they're women and it doesn't line up, they're just thinking, oh, it's my shoulder, it hurts a little bit, or something else.
There you go.
When it's actually something serious. So
Yep.
I definitely agree.
Here,
Yeah.
Irving talks about, my nurse friend told me that a BP cuff, if wrong size, can affect readings. So true. So true when it comes to that. Did y'all want to hit on that real quick?
No, I hit that point, earlier. That's why it's so important to make sure that your tools are properly calibrated. You're making sure that it's charged or have the right batteries or all those things, and utilized properly. So, using the right cuff is going to give you the right reading. So make sure you do that for sure.
Absolutely. Seen it too many times where people have had false readings in the hospital because they're using the wrong cuff.
Yeah. So they're
definitely.
freaking out, they freak out about the number. And that's the thing too. Just take a breath, relax, and try to, not spark up an issue more so than it is.
Mm-hmm. So here it says, healthy lifestyle, exercise for prevention. Your pelvic floor is a powerhouse that deserves some TLC. Regularly doing Kegel, squeeze, hold, release can keep everything in working order. No equipment, no gym membership, just a little focus and a lot of pelvic pride. So next time you brush your teeth, squeeze, sitting in traffic, or pretend to listen in a meeting, because I know for a fact I don't listen to meetings at all. I'm on Instagram or TikTok or something like that. Squeeze those muscles. Your bladder, sex life, and future self will thank you. One thing I find interesting was Kegels. Every time I hear the word Kegels, I think women. Because honestly, you always say you see Kegels. But I didn't know that till you brought it up. I was like, what? That's like, we do it all the time, all the training, the pelvic and everything. I understood that. But then when you broke it down, I was like, oh yeah, we do have those muscles as well when you're pushing out.
Muscles. Yeah.
I didn't think about that. I know. Poor little me. I know.
No, I mean, one of the questions that I do get is, how do you do it? How do you isolate those muscles? And it's kind of simple, because I think all of us at least have done it at least once or twice in our lifetime. Like, just think about when you are urinating and for some reason you need to stop, like if you're giving a sample or something, and then you keep going. Those muscles that you use to stop your flow, that's what you're trying to isolate. And that's essentially you doing a Kegel to stop the flow. So try that the next time you're urinating, so you can get used to, okay, that's what that muscle feels like. And then obviously when you're not, if you're sitting in a meeting, like you mentioned, you can try to isolate those muscles. So you want to hold it in for a few seconds and then let it go. And then you can do like 3 sets of 10 like that.
Okay. And up here, just different topics. If y'all want to hit this, that'd be great. I put it more like a tic-tac-toe kind of thing, where in the middle section itself, here we go. In the middle section itself says exercise to help with the pelvic floor and any of these. Did y'all want to expand upon that? Because honestly, I know you all will face this with your patients. So if y'all want to hit that real quick, if you don't mind.
Yeah, I wanted to bring up something that we talked about kind of before the live started. One thing that I recommend for patients, or that I'm going to start recommending to all my patients who have been pregnant, whether they had a vaginal delivery or not, is pelvic floor physical therapy. Because if we think about it, over the course of 9-10 months, you have the weight of your baby and their fluid and your placenta that's basically sitting on your pelvic floor muscles, in addition to the progesterone, which is making all of your muscles relaxed and everything. And so that puts stress and strain on those muscles there. And so they can kind of get fatigued and less strong, if you will. And so going to a certified pelvic floor physical therapist can help you get the right exercises to build those muscles up, because all muscle can be toned. And so that can help with the health of your pelvic floor. Now, specifically for patients who have had vaginal deliveries, had traumatic vaginal deliveries, it is absolutely imperative that you go to pelvic floor physical therapy because they can help you kind of work through those things. If you have those trigger points that develop, as I mentioned before, they can help you work through those things. They can do different exercises. They can prescribe you different machines, such as a TENS machine, to help work out those muscles and promote the health of your pelvic floor. So I just wanted to make that plug for pelvic floor physical therapy.
Got it. Nailed it.
All right. So in this, like I stated before at the beginning of the live, at the top of the chat, we have the actual presentation pinned at the top. So if you go to the top, you click on that, you will actually see the live presentation. In addition to that, we do have different links that you can click on. For example, right here, if you click on this link, it just takes you to a reputable website where you find more information on exercise for prevention or Kegels and things of that nature. Like I just learned, for us guys, we should be practicing that too.
Absolutely. So I'm doing it now.
Okay, fool with you. I'm doing it too. I'll be doing it in the meeting. My meeting, so because I ain't paying attention anyway. Hopefully none of my admin are on right now because they know I don't pay attention. Okay, so one thing I want to ask for Doc, when it comes, either Doc, here, pelvic floor exercise, the Kegels to reduce pain. We talked about that. Now, for this, the pelvic floor drops, reverse Kegel. What exactly is that? Are y'all familiar with that?
Reverse.
I mean, my thought process take me somewhere else. So, but
I know that one. You're supposed to have the link that goes straight to the exercise, and then
I do. It's right there. It's right there. I didn't want to.
You know what the beauty is nowadays? You can Google it. YouTube is a great resource, so you can put that in there. You can put in pelvic floor exercises, and I guarantee there is a video that goes through everything, or some certified pelvic floor physical therapist who is online, and they will take you through it. I promise. If you want to see like pictures, you can just Google that and exercises will come up. But if you are a visual learner and want to go along with someone telling you how to do the exercises, YouTube is your best bet. YouTube has everything. So I would recommend.
Yeah, I was actually on a panel a couple weeks ago with a physical therapist that specializes in this. Her practice just revolves around this. And I was like, wow, like, you know, when you talk about really specializing in something, this is, you know, kind of joking about it, but it's really much needed. Like, you know, when a female is having a child, you know, Dr. Lyons talked about this, that's a traumatic event. And so, you know, to regain that strength, balance, stability, and it's just, it helps to the overall recovery. And it helps a lot of women to even with issues where, you know, they're having issues with incontinence and all those things that go on. They can't hold their bladder properly, where those muscles get weak. You know, that's a big topic, big topic there.
Okay. So looking at this here, we're talking about the nutrition for women, or basically we're focused on women's health. So when we're looking at this, did y'all want to hit this? I know both of you talked about this earlier, Dr. Coy. We talked about this, especially the bottom right when we're talking about anti-inflammatory. And Dr. Lyons, we talked about this last live as well. So did y'all want to hit this real quick? Just talking about the healthy lifestyle with the diets.
Yeah. I would say I agree with probably 95% of this slide, because it's very general, but the hydration is important. You know, you got to make sure you're drinking, you know, clean, filtered water. You know, you need that. Majority of the body's made of water. You need that. The DASH diet, the only thing I would say I don't really agree with is the dairy. You know, just from the standpoint of, you know, it can cause some issues with inflammation, you know, depending on the person that we're dealing with. And there's numerous reasons why a person shouldn't have dairy, but, you know, that's an individual matter there. and even with fruits as well, you know, depending on the person, depending on the condition of that person, you know, just really watching how much fruit that person is ingesting. Vegetables and good protein I'm all for. And obviously with omega-3s, the standard American diet is AKA the SAD diet. And so it's going to not have those fatty acids that you need to help the body, those omega-3s that you find in those sources like salmon and flaxseed. It's really helpful for the heart, but it's anti-inflammatory. So so you want to make sure that that's there. And so that really leads into that anti-inflammatory foods to help with pain. But it's not just pain, it's just overall health. You know, inflammation is an immune system response that you need to have. But when the body is inflamed for no reason, and the body is not, well, when the body is not able to handle its insults and causes lots of inflammation and is overburdened with that, that becomes a problem. So making sure that you're not just putting fuel into your body that is going to cause that. And sodium, not only sodium, but, you know, all your other vitamins and minerals, your potassium, your magnesium, you know, all your B vitamins. Basically, you know, you want to make sure that you have not only the electrolytes, but also your vitamin and minerals for sure.
Yep.
Dr. Lyons?
He's a wellness expert. I agree with him.
Thank you. Thank you.
I take it. Good job, Dr. Coy. Good job.
Thanks.
So it's actually going on an hour and 11 minutes. So we're going to wrap this up. So what did we learn today? So if you take a look at the screen, this is what we actually learned today. Let me move the screen this way. There we go. This is what we actually learned today. He's talking about what causes chronic pelvic pain in women. So Dr. Lyons did hit that real good. How to spot symptoms of endometriosis earlier. So perfect job on that. The difference between preeclampsia and eclampsia. They have similar signs and symptoms, but they're also different. And also, Dr. Lyons talked about eclampsia can happen postpartum, which I did not know. I literally thought if you delivered a baby, you ain't got to worry about nothing. So that's something new I learned today. So thank you for, I learned something. If nobody else did, I learned something. So, and Kegels, but we're going to leave that one alone. Why heart disease is called the #1 silent killer. So that's very interesting. In the warning signs, women ignore but shouldn't. Because again, for women, you're a lot stronger than guys. I ain't gonna lie. You push a baby out, it ain't gonna happen. I'm like, Doc, what time you want to cut this baby out? I ain't pushing. So you ignore a lot of the pain just to push through. So again, if you feel the pain, hey, hit the doc up. That is very important. And lifestyles, diet tips to prevent these conditionings. So we hit all of that. Key takeaways when it comes to that for the chat. And again, for the chat, since you're here, what's one health change you will act on this month? Again, we know this is May, and it's May 19th, so it's midway through. But what is one thing that you would change based on your health? Again, thinking about this live, the previous lives, what is one health change you want to act on this month? What is one thing you want to do different? I know Carmen Q was talking about, hey, she's dieting and exercising even more now, or I won't say dieting, but living a healthier lifestyle. So that's one thing. What about anybody else in the chat? What are some things that you all are doing? For me personally, I'm increasing my cardio. That's one thing, because I get in the gym and I just sling heavy weights, but then all of a sudden I'm like, okay, I might want to do a little bit of cardio to help me out with that. Yeah, I don't eat a lot of sugar, but my endurance compared to when we were in high school. Yeah. I ain't cross country running no more. Then I was like 160. Now I'm like 230. So yeah. I got to increase that cardio slightly. Yeah. So for the chat, is there anything that you all are looking to change? Again, this is May. And we talked, Dr. Coy and I, we talked about this earlier. At the beginning of January, everybody's hitting it hard. Going in, hitting the exercise hard. Then now it's May, and gyms have cleared. So what are some things what are y'all are doing that you want to do? And even for you all on the panel, Doc and Doc. So what are some things? I know G23 says, I've been cutting carbs, eating more salads and plant-based proteins, which is a good thing. And Dr. Coy talked about that as well. And I can never say that chart. What's the name of that chart again? The red and the...
Oh, the Andes list?
Yeah, the Andes list. See? Yep. I need to post that, the Andes list. What are some things you all are doing for the month of May, just to change up a little bit?
Yeah, for me, well, Dr. Lyons, you want to go first?
Sure.
Yeah.
Well, I'm in the middle of a move. So I have moved my life from Alabama to Virginia. So it's been a little bit hectic. I'm also on the back end of recovering from a back injury. So my goal is to get back into my cardio swing because I was doing really well with, I don't like running. I actually hate it, which is ironic because I was a college athlete. I hated it then too. But I do like to walk. And when I walk, I power walk. So my old neighborhood was really great. So I would do like 6 or 7 miles. It was wonderful. So my goal is to get back into that and also limit my sugar because I'm a sugar fiend.
Yeah, I mean, May is mental health awareness month, and I've really been looking at a very powerful book. It's called Atomic Habits by James Clear. And so just going through that book to reevaluate my habits and also sharing that with many of my patients. So we have almost like a book review, but really gearing it to type 2 diabetes and how we can really shape our minds in the right frame to create the tiny habits that actually make remarkable results over time. So just getting our mental health together, really spending time, meditation, prayer, but also just mindset. I think that's important so that we can, just improve overall. So that's what we're doing.
I'm gonna work on my Kegels.
Keep it up, man.
I'm working on my Kegels. I pick on it, but it's so funny because I've never thought about that. So it's like, you know what? I'm gonna actually work on that. See how that works.
How you know you're gonna get better?
I just trust
myself. How do you know it's improved?
I trust myself. When I'm taking a bowel movement,
you'll know if you get fatigued or not. Like if you really working it, you'll know. So
it's like a burning sensation, or like you lifting like you doing.
I wouldn't say it's a burn, but you'll definitely know.
You'll know.
Okay. You'll know. Don't have step though. If you have step, you know.
So I'll know.
Yes, you will know.
Will I be weak in the legs or just weak in that?
No, she said you'll know.
You'll know. How would I know? What do I look for? I'm like a person. I don't want to work
with it because there does come a point if you're doing it properly that you could get fatigued. So like holding the muscle and then releasing it. So you can start small, like, I don't know, 4 seconds and work your way up to 10. So if 4 seconds is easy, then you need to bump up the number.
Oh, okay. Because that's like if you're in a crowded area and you got to pass gas, so you holding it in, something like that?
Yeah.
Okay.
That's Kegels?
No. I explained it. That was an analogy, right? That wasn't like a real.
I was serious.
I didn't know. I mean, you brought it up. She's frozen.
She's frozen. Yeah.
At the right time.
I was serious. I was like, it's like a gas. I don't know.
That's great.
All right. Sorry about that, chat. All right. So it's been an hour and 18 minutes. I want to thank you all for actually joining us and interacting with us. We great job today. I really enjoyed this. If you got a chance, please share this. Please share this live and all our previous lives with any of your friends and family that you think will be helpful. This information will be helpful too. We'll be back again. What's our next topic? What we want to talk about high blood pressure. We can hit high blood pressure a little more. We hit thyroid, which is a good one.
We're getting into June, right?
Yep, going into June. Yep.
Let's see. What can we talk about in June? Let's see.
While he's looking up chat, if there's something you want us to talk about in June, let us know. Just send us an email, hit us up in the comment section. Let us know what you want us to talk about. Also, at the end of this live, if y'all can just make a simple comment on a simple comment and just post that'd be perfect for us, just to help us get an algorithm to push this information out there to more people. And what's up?
Men's health.
There you go. So we talk about men's health in June. There we go. Yeah, because we got Father's Day coming up. So yeah, why not?
Yeah.
All right, so with that said, it's going an hour and 20 minutes. Thank you all so much, and we will see you all next time.
Take care, guys.